Hi, how are you? Hi. Sorry, I cannot hear you. Can you hear me? But I cannot hear you. Maybe you can try. Just some technical issues. So we're gonna start in a short time.
Can you hear me now?
Yes, yes, very
Good.
clear. How are
I'm
you?
sorry, but I had some technical issues here.
Mm-hmm. It's
But
okay.
we're fine now
Mm-hmm. It's okay.
and we
So
can start.
yeah, so let's start. Yeah, and all the students
Whenever
are ready.
I turn on the video, unfortunately, something happens with my uh, internet connection. So I will not open the camera right now.
It's okay.
And we will take it from here. You have to make me a host.
Yeah. Okay,
I need you
okay.
to share
Let's
screen.
let's start after I finish some introduction. Okay.
Yes, definitely.
Yeah.
Definitely.
Okay, so sorry for the late and we're gonna start now. Hello everyone. Welcome to Aohua Webinar. I'm the host from Aohua and our company was established in 1994. And we have focused on endoscopy system for almost 30 years. And with these monthly webinars, and we aim to bring all the veterinary endoscope users or the beginning users together to share the knowledges and experiences. And we also have some clinical cases on the YouTube and some workshop offline with our distributors. So if you are interested in it, please follow us social media and contact us. Okay. So next, let me introduce our speaker today, our old friend, Dr. Vasiliki. She is qualified from AUTH Greece, and her clinical interests including canine and feline gastroenterology, nutrition, and diagnostic interventional endoscopy in companion animals. And she also holds a GP cert in small animal internal medicine and a GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate, and also a PG cert in small animal medicine from Harper Adams University in UK. And she is also an invited speaker in multiple seminars, webinars, and trainer in some workshop. And she is also awarded by AAFCO. Okay, I will give you the host, and you can share
Thank
the
you.
screen
Thank you
now.
very much. And I
Yeah.
will try to fix my camera because I want people to see me.
Uh-huh.
It's more, keeps them, you know,
Yeah.
more awake. I
Yeah.
will try to
Yeah.
find
It's
a
okay.
way.
I have give you the host. You can try it.
Good. And now you can see my screen.
Yeah. Very clear.
Okay, rhinoscopy. This is an amazing topic today. And rhinoscopy is one of my favorite subjects. And it's a huge subject. I know that for many of you, the noses are a bit difficult to approach, especially due to the anatomy of the nose. So this is going to be the first part. We're going to do next month another rhinoscopy session as well, because there are a lot of information that I want to share with you. This is going to be today the more boring part, because we're going to talk about anatomy, because if you don't understand anatomy and the instrumentation that you want to have, that you need to have, you will not be able to perform a good rhinoscopic procedure. Okay, and let's see why do we prefer perform rhinoscopy. We can perform rhinoscopy because this way we have visualizations of all the lesions that exist in the nasal cavity, and not only in the nasal cavity, but also to the nasopharynx, to the frontal sinuses, with a bit of intervention there, of course. And we can have diagnostic sample collection. Let me check now my screen. Maybe you can see me now. Good. We can have a lot of diagnostic samples collections from the during the rhinoscopy procedures, like cultures, biopsy. We can also have cytology samples. We're going to talk about the diagnostic validity of the deep cultures later on, because you're doing, let's say that you are an expert in performing the procedure. The problem sometimes is that you take samples that cannot give you the answer to what your patient has. So the whole procedure is like useless. So let's talk about which samples, when, and how to collect these samples as well. Also, besides the diagnostic endoscopy, we can have the therapeutic endoscopy, the interventional rhinoscopy, where we can have foreign body retrievals, where we can have the aspergillosis treatment, and also perform some operative procedures like nasal tumors debridement. Of course, these are palliative treatments. They're not sometimes curable, but they allow the animals to breathe, to secure an airflow, a very easy airflow. And this is what we want, quality of life, because many of these tumors are not even chemo sensitive. So the only thing that you can do is tumor debridement over time, up until the animal has no other quality of life. And of course, to treat the nasopharyngeal stenosis in cats mainly, due to the chronic inflammation and the chronic retrograde nasal discharge. And this is common practice right now. We do not perform an open surgery for nasopharyngeal stenosis. For these patients, we treat them with the balloon dilations and also with the nasopharyngeal stents, which I will show you in a while. And now we're going to go to the most difficult part. There's an amazing article that you are able to have a look if you really want to see what's going on in terms of anatomy and functionality of the nose as well, because we definitely have to know that in order to collect, as I said, in order to be able to orientate ourselves in the nasal cavity, and also to collect the correct biopsy samples. So you see here that we have the nasal turbinates and the ethmoid turbinates, which are different in anatomy. And I will show you how endoscopically they look so that you can orientate yourself. Where am I in the nose? We have the olfactory bulb and this amazing, the VNO organ, known as Jacobson organ sometimes. This is highlighted in yellow here. And this organ is the main responsible to actually detect all the fragrances, all the smells. And also, in particular, it is believed to play a very important role in social behavior and reproduction. Why? Because this organ can actually detect the pheromones. Okay, so these are the all the parts of the olfactory system, and we should be aware of these parts. And this organ here as well, the VNO, I'm not going to say the whole the whole title of the organ. So the VNO is also responsible for the Flehmen reflex. You might have watched the Flehmen reflex in a lot of your patients, but you might not, you might not have known it. Please write in the chat box who of you know the Flehmen reflex and what it is. It's very interesting because I was doing endoscopy for, like 1 or 2 years, and I knew the reflex, but I didn't know the name of the reflex. Anyway, let's see how it is. Look at this cat. Do you see the mouth? She smells first, and then she opens the mouth, and the tongue is a bit protruded. Let's watch it again. It's very, very common in horses when they smell something profound and they're doing this thing with their upper lip. In cats and dogs, this is not observed as in horses, but because the lips are very rigid and very firmly fixed, as you see in the frenulum. And let's watch what the dogs do. You might have a lot of they do this muttering with their let's watch it again, with their mouth. And a lot of your clients might tell you that my dogs, start salivating when they go out for a walk, or because they smelled urine, for example, of another dog, or the feces of another dog, or pheromones, and they start smuttering their mouth. Okay, so in cats, it's an open mouth, the reflex, and sometimes the cat licks the nose area, and they just stand as if they're motionless sometimes. And in dogs, it's this muttering of the jaws. Okay, it's very, very interesting, and this is called Flehmen reflex. Okay, and let's go now to anatomy, which is, the most difficult part, but we really have to know how the nose is organized so that we know where we're putting our scope. So we have the dorsal part. We have 4 endoturbinates. Okay, we have the dorsal part, which is the endoturbinate 1, which is here, as you see. We have a ventral, and we have also another section of the nose. And as you see here, we have the dorsal part. What we're interested mostly in rhinoscopy is the dorsal, the medium, and the ventral meatus, and the common, which actually is the common meatus of all of those, and it's aligning with the septum. It's the most easy path to orientate in the nose, the common meatus. Okay, and this is, as you see here, the common meatus. We have the dorsal, the middle, the common, and the ventral nasal meatus. And even if you're the most competent endoscopist, you will not be able to scope the whole nose. There will always be parts of the nose that you will not be able to reach. So when we're exploring, for example, for a foreign body, we have to be very, very meticulous and very elegant in our movements, so as not to cause hemorrhage, so as to be able to continue our procedure as well. You see the nasal septum here, and this is one of our landmarks of orientation as well. And the turbinates are the organ that actually contribute to increase the mucosal surface of the nose. The nose is the most has the most increased venous network in our body. This is why we have it's hemorrhaging so much, even with the slightest touch. Okay, and 5 to 15% of the air that is inhaled is redirected into these turbinates. The inhaled air, how does it flow? So the inhaled air goes through the nose, enters the nasal turbinates, and then it goes to the neurons, to the olfactory receptor neurons. Then it goes back to the ethmoidal turbinates, and subsequently to the larynx and the pharynx. And as you see here, we have the middle meatus, the dorsal meatus, the ventral meatus. This is the alar fold, and the movement that we do when it's not only anatomy, because when we take the scope, the alar fold has to be protrude, has to be brought upwards in order for the scope to enter. Otherwise, you will hit a wall. And it's the first disappointment while we're doing the rhinoscopy procedure. So the alar fold up, and then we insert our scope. And the difference with a cat, sometimes people ask me, how do you, scope, do rhinoscopy in cats? Do you use very, very thin scopes? No, I use the same scope that I use with dogs, the multi-purpose one. It's just that you have to be more cautious and more elegant in your movements because you might cause a lot of hemorrhage and you don't have a lot of space. And it's true that in the cat, the ethmoturbinates are larger. So this doesn't leave you a lot of space to work when you are not rostrally, but you're more backwards in the nose. And the nasal turbinates are smaller. So as you see here, in number 1, we have the nasopharynx in the frontal sinuses. The 3 are all the ethmoid sinuses. So this is a large area in the cat. And the 4 and 5 are the 5 is the middle nasal meatus, and the 7 is the ventral, which actually leads the common, and the ventral meatus always needs to lead to the nasopharynx. This is what you have to keep in mind. When you don't know where you are, you go next to the septum. And then if you go ventrally, what you will not see is the light of your scope. So you know that you're ventrally, because a lot of people ask me in workshops, how do I know that I'm not dorsally, that I'm ventrally, if I'm not experienced enough to understand how are the ethmoidal turbinates, and how is the anatomy of the nasal turbinates, for example. You can see your light if you're dorsally, the light of your scope, okay? And this is very, very, this actually brings up an alert, because you cannot go past the eye. You will cause blindness to the animal. So when you don't see your light, then you're ventrally. And this is, as we said, the ventral and the common meatus are the only ones that lead back to the nasopharynx. If you have any questions, or if you have performed rhinoscopies before and you want to discuss some things about the anatomy, about what you're seeing, please put all your questions in the chat box. And let's see a bit the indications for rhinoscopy. Most of the times you will see a lot of indications, and we will talk about indications, but most of the times rhinoscopy procedures are meant for chronic cases, not for acute cases. For chronic nasal discharges, either retrograde chronic nasal discharge or orthograde, anterograde nasal discharge. And as you see, we have a lot of patients that are sneezing paroxysmally. The only acute event that you will actually perform rhinoscopy are the foreign bodies. Okay, We have sneezing and also the reverse sneezing, which we will see. Sometimes it's very, very tricky to detect if an animal is reverse sneezing or coughing. Nasal discharge, is it unilateral? Is it bilateral? Epistaxis, which is blood from the nose, or rhinorrhagia, hemorrhage from the nose. Stertor and stridor. I know a lot of colleagues that still were not able, all of us sometimes we're not able to detect which is stertor and which is stridor. And they have a totally different origin, these two sounds. So leaving here today, I really want you to be able to detect all the symptoms and their origin, where the sounds are originating from. So the stertor is snoring and snorting, and the stridor is an inspiratory noise. It sounds like a whiz, and it's actually produced in the nasopharynx area, in the nasopharyngeal area. I have a slide about that later on. And we tend to hear stridor in animals that have elongated soft palate, in the Boas syndrome, in brachycephalic breeds, and also in laryngeal paralysis, for example. Some animals are admitted with gagging and choking, and this is nasal disease symptom. The easiest ones are the ones that come with rubbing their nose or their face, showing us that there's some kind of an irritation at this point. We can also have facial or nasal pain sensitivity. Some owners actually observe that if they touch the nose or the area around the nose, the nose, the animal becomes agitated and aggressive. Also, if we have cases that have been neglected in a term, we can have facial swelling or distortion of the face. And this happens very much so in tumors, but not only in tumors. And I will show you a lot of cats with calicivirus. They have a strain that actually causes this facial swelling, and we have septic, actually skin dermatitis in the area in some of these animals. Also, we can have oral or nasal odor, hepiphora, which is having a lot of tears from the eyes, or unilateral or bilateral as well. It depends on the illness. Ulceration or discoloration of the rhinarium or the nasal planum when we have chronic nasal discharge in aspergillosis, for example. Maybe in the history we have a knowledge of foreign body inhalation, and it's most of the times they go out for a walk. We have this period of grass awns that are really, really dry, and they're inhaled in the nose. Or knowledge of foreign body ingestion with consequent vomiting. What does this mean? We have a lot of cats that actually have reverse sneezing, and we find grass in the nasopharynx, grass awns in the nasopharynx that have been vomited. So the cat consumes grass and then vomits, and all the grass and foreign bodies go to the nasopharynx. I have seen even trichobezoars in the nasopharynx stuck as a foreign body sometimes, because they vomit and the ball of the hair ball goes and gets stuck there. If it doesn't go, sometimes they swallow it and or it's stuck to the esophagus and it causes esophageal stricture, but sometimes it goes up to the nasopharynx. And of course, head shaking. And this is the different location between stertor and stridor. Okay, so stertor is characterized by snoring And the location is nasopharynx and palate. And stridor, I'm sorry, I think that I have said stridor before. Stridor is in the nasopharynx, okay? And stridor is like a wheeze sound that is generated by the larynx, okay? So the stridor is produced here, and the stridor is produced in the nasopharynx. So for our for today's topic, what we're most interested is the stridor. I don't remember if I mixed it up. You will tell me. I think I said stridor before for the nasopharynx. It's stridor for the nasopharynx. Okay. And there are also some contraindications for the rhinoscopy. When we have primary or secondary hemostatic defects, when we have coagulation problems, we first have to correct them and then go to perform the rhinoscopy procedure. Watch out your liver diseased patients that have that should undergo for some other reason rhinoscopy. You definitely have to check the coagulation because in liver disease patient, this is altered. This is not normal. The coagulation profiles are not normal. Okay. In cases that we have hypertension, in cases where the disease has progressed that much that it has reached the cribriform plate and it's next to the brain, this is really, really dangerous. In order to cause encephalitis and dissemination of the inflammation, okay? And in cases that we have increased intracranial pressure, in all of these cases, I would not perform rhinoscopy. I would first stabilize my patient and then proceed into endoscopy. And in general, I want to mention something because I know that the first choice that you think you're having when an animal exhibits certain symptoms is rhinoscopy. Rhinoscopy is on the bottom of the list. First, you have to perform all your other tests, as we will say later. And the last one to be performed is rhinoscopy. Because if you perform, for example, rhinoscopy and you don't find something, you don't get good biopsy samples, and you then want to perform your CT scan in order to find out what you missed, this is going to be a disaster because you will have iatrogenic trauma from the rhinoscopic procedure and other lesions that you have caused with your scope, and you will not be able to go for a proper CT scan. Okay, let's see this little kitten here with nasopharyngeal stenosis due to a callicity, to a chronic. How much chronic? I mean, this kitten is so small and so young, yet there was a nasopharyngeal stenosis. This cat had retrograde nasal discharge for more than 3 weeks. And you see how it stretches the head and tries to breathe. Okay, with an open mouth. And this is a kind of reverse sneezing as well. It's not actually reverse sneezing. This patient is dyspnoic and tries to take in some air because both of the nasal conchae are blocked. And also a lot of retrograde nasal discharge is coming down, blocking the airways as well. And let's go here. This is the case that I told you before. You see that this cat, the owner actually, when the case was referred to us, said that this cat is coughing. And actually, it is like a coughing reflex. But you see that in between this coughing episode, the cat actually stretches the head and swallows retrograde nasal discharge. That's also due to a grass, actually a bunch of grass material that has been stuck in the nasopharynx. And of course, look at this one here. When this patient was referred to us, it was referred due to actually neurological disease. This is what they thought. That this patient is trying to gasp some air, to breathe in some air, and this is reverse sneezing. And it does a kind of reverse sneezing. So you see that this is not, cat clear. This is not the typical reverse sneezing that we see in dogs. Cats are totally different. Okay, and the trio all together. Okay, and let's see this dog with a reverse sneezing and with lymphoplasmacytic rhinitis. You see that they do something like an abdominal breathing. And this dog was allergic, actually, because we did all the tests. We did rhinoscopy. The cause was lymphoplasmacytic rhinitis and could be due to allergy as well. Now let's go see this one as well. This is more typical because you see that the lips are stretched behind. And this dog also has laryngeal paralysis, so the reverse sneezing is even more intense because the sounds, we have a mixture of sounds. I'm sorry, but these videos are from the owners, so I'm sorry for the foot and the feet and the legs that you're watching as well.
Vasilikki,
Okay.
sorry to interrupt you.
Yes.
I thought we cannot hear the sound of the video. Maybe you need to, there's an option, you need to share the sound together when you share the screen.
Okay, where do I do that?
When you share the
Cannot hear
screen.
the sound of the videos, you
Yes.
mean?
Not only the video from the screen, from the presentation.
Okay, let's go back a bit and see.
Yes. I think you need to share the screen again and need to choose the option to share the sound of the screen together.
Share the sound of the screen. Okay.
Yeah, yes. You can check it. And maybe at the corner at the left hand. Can you see it?
Yeah.
Yeah.
Let me check.
Mm-hmm.
It says leave computer audio. Speakers.
Yes. We can try it.
Leave computer. I left computer audio.
Maybe we can check again. Try again.
Yeah, let's. Okay. Let's check.
Mm-hmm.
No, let's check this one.
Mm-hmm.
No?
Well, for me, there's no sound. If any others can hear the sound or cannot hear, please say it in the Q&A box.
Yeah, let me check once more and
Okay.
Check now.
Okay.
Now? Not? No sound. Oh.
No.
Let me check.
Yeah,
Because I can hear it now.
Yeah, because I remember you need to choose the option to share the sound of the presentation.
I do not find any other audio settings.
When you share the screen, when you choose the presentation.
When I share the screen, then there is automatically share, scale, zoom, maximize, recording, zoom apps. No. What I can do though is send separately the, you can't hear, I'm so sorry guys, but we will send you separately the videos. This is what I can do. We can send separately the videos. Otherwise, you will have to show me beforehand, because here I select a speaker. Okay,
maybe can you sorry, can I have the host again? Can I have the host again?
Now can you hear me?
No video, only your voice.
Now you can hear me?
Yeah, we can hear your voice, but no video voice.
No video voice. Okay. The only thing that I can do is share the original videos so that you can hear the sounds. Is that okay with my colleagues? Is that okay if I send you the original videos? Yeah.
Maybe can I try? Can I try it?
Yes, definitely.
I'm gonna take the host.
Yes, definitely.
Yeah.
Definitely.
Sorry.
Definitely. Oh, we're so sorry for this interruption.
It's okay. Sometimes the technical issues will happen.
Yeah.
Let me try.
Okay. Up until Jason tries, please tell me, do you do rhinoscopy? How many of you do rhinoscopy? Are you starting now? Are you doing it in an efficient way? Write in the chat box. We will talk next time. We will have a lot of cases, and we will talk about interventional endoscopy. This is a very introductory course in order to find out about the anatomy, to find out about the indications, the instrumentation for people that do not do endoscopy at all, rhinoscopy. Oh, great, David. I'm certain that you will do, and you will send me mails and, your updates. So this is mostly great. Nazenda. So this is mostly for people who are starting now, but we will say some tips on how to make, even for those who are proficient in rhinoscopy, some tips that will make your life easier and into doing the procedure. That's great for Gu. You're doing the procedure in the imaging center, so you have a dedicated imaging center. And you're doing the procedure there, which is very good. It's always good to have your rhinoscopy procedures next to your CT scans, because with the same anesthesia, you can do both. First, the CT scan or radiology, and then your rhinoscopy procedure. Yeah. Jason, are we okay?
Yeah, I've sent you WhatsApp. Please check, and I've give you the host authority. Can you share the screen again?
In WhatsApp you've sent me.
Yeah, I've sent you the picture how to share the sound. Yeah,
How to do it.
just one option. You need to open it when you share the screen.
It's in Chinese, Jason.
I know. But maybe the same. I know the same location. Can you check?
Yes, this is what I'm doing. This is what I was doing. This is what I was doing. Audio settings. And it says audio profile. I don't think that it will work. Original sound, original sound for musicians, live performance audio. What should I click? It's a lot
Can you show me? Can you show me your screen?
Yes, but I don't want to, because I know that people have their practices.
Yes.
I will go on, and we will come later back if you tell me to press on something.
Okay, maybe we can. Let's continue.
Tips and tricks, yes. That's true. Nadezhda. I'm not pronouncing your name correctly. You should teach me how to pronounce the name. Okay. So what should I ask the owners when they come? The duration of the problem. You should write that down. We have specific forms at the clinic when we write down everything. So the duration of the problem, acute or chronic. For example, this poor kitten was like 2 months old and 2.5 months old. And how can you say about chronic problem? This is what the referring vet told me. But if it's a chronic ongoing nasal discharge, then it's chronic. It's considered as a chronic problem. Okay, the progression of the disease, is it a steady deterioration, or does it have wax and waning symptoms? So it disappears and reappears. For example, in allergic diseases or in idiopathic lymphoplasmacytic rhinitis, we can have wax and waning symptoms. Whereas where we have a neoplastic disease, or when we have aspergillosis or another nasal disease that deteriorates over time, then this doesn't wax and wanes. Okay, it has a steady progression onwards. Is it a unilateral or a bilateral problem? Has the same side been involved throughout the whole course of the disease? Because sometimes, you know, it begins with one side and then it goes to both sides as well. And we always have to see and to write down which side was the initial one, and also check the eye on this, on the unilateral, on this side that the problem started, and all the other anatomical structures as well. Species and breeds, because there are some breeds, for example, that have, like the boas in brachycephalic breeds, or so they have nasal problems due to their anatomy. Okay, or we have aspergillosis, for example, in the dolicephalic breeds as well, or some skin problems in these breeds that actually involve the nasal planum. The age of the onset, if we have a geriatric patient, it's only natural that we will think about neoplastic lesions as well. The character of the discharge, is it serous? Is it mucopurulent? Do we have epistaxis, as we said, because we have to check the gangulation profiles? Is the nasal discharge unilateral or bilateral? So if we have unilateral, this not always, but this doesn't address a systemic disease. Could be a foreign body, could be a neoplastic lesion in one side only, for example, whereas bilateral has more the character of a systemic disease. And also always ask if the nasal discharge has changed throughout the course of the disease, which means that if in the beginning it was serous and then it became mucopurulent, this means that we might have a secondary bacterial infection. Always ask about trauma. This poor guy here was admitted. This is the imaging in our clinic. You see that it's coughing. I know that you cannot hear it, but it goes like gagging, goes like that. And also the X-ray table, the radiographic table is full of blood. The tongue full of blood. It swallows blood as well. Okay, and it's bilateral. It's bilateral. Should I consider a foreign body, for example? I wouldn't do that. I would first do my whole profile, coagulation profiles, biochemistry, in order to be certain, check the liver, check for lichiosis, check for other diseases that might cause vasculitis, okay, primary or secondary coagulation. And then I would go into performing endoscopy in a bleeding animal like that. Okay, we have to think twice, even if this animal was admitted for sneezing blood. This was what the referring veterinarian said. I wouldn't rush into scoping this patient, okay? And we have this geriatric Labrador that has, you see the discoloration of the nasal planum and this whitish nasal discharge. And this was aspergillosis. And of course, there is this huge range of infectious diseases like distemper virus, the canine influenza virus, the pneumovirus, the respiratory coronavirus, which is very, very, that came, it's very up to date with the current episodes of coronavirus as well in humans. You see here that we have some serous and mucopurulent, bilateral in infectious diseases. Most of the times this is bilateral. And I want to go here into the cats, and I really, really want you to be aware and to know that we might have, yes, calicivirus might give you the ulceration in the tongues, the ulceration in the oral cavity, nasal discharge. We have an implication of the eyes as well, but it can also be manifested with distortion of the face, and sometimes the whole skin just rottens. It has very, very bad infection, and it just goes apart like here, and even higher up in the sinuses, in the area of the sinuses. Okay, so if you see that and you give antibiotics and they don't go well, they do not respond. So if you see that, think about calicivirus in these cats and the ulceration that calicivirus actually originates from the calicivirus infection. Okay, and some other times we might have this kind of facial distortion with chronic inflammation, with abscesses, with a lot of things, with neoplastic lesions, okay, and the facial deformity, you can see it, okay, and you can palpate it, and you will always do that. In this cat, it was due to soft tissue, it was due to a soft mass in the nasal region. What else should I ask? Is, as we said, is there any facial pain? Is the animal, and if you ask the owner this question, the owner will say, well, I don't know, but you can ask him, when you go and pat your dog or your cat, does it get to be more aggressive? And he will say, yes, I've seen that he closes the eyes like blepharospasmus, and that he goes away, that he seems like he's afraid of things that he wasn't afraid before. Even before any nasal deformity appears, you might see these symptoms: scratching or rubbing at the nose or at the face area. Sometimes they rub their eyes as well, but it goes for the nose because they feel discomfort. Changes in the shape and the contour of the face, which are really obvious. And sometimes they're not that obvious. Sometimes you only have a protuberance of the eye, and you see an asymmetry, that the two sides of the animal are not symmetrical. Okay, dyspnea, increased breathing sounds, environmental exposure to toxins like rodenticides, okay, that might cause epistaxis or hemorrhages, and other concurrent illnesses like infectious diseases. Ask if the animals are vaccinated. So there are a lot of questions to ask when an animal is admitted for rhinoscopy. And I know that it might seem to you very, very preliminary, and okay, this is, we know all of those things, but most cases that are referred to the clinic for rhinoscopy have not undergone all this detailed clinical history, and they have missed something on the way. So how do I approach the nasal disease? We have three phases. The first phase is the signalment, history, physical examination, and all your pre-op biochemical CBC coagulation profiles and serology. The phase two is when you finish with all of those things. The phase two is CT, radiology, which, we have substituted now radiology with CT scans. For those of you where CT scans are not handy or available, then you can still have your radiographic examination, and I will show you how to do it. MRI, and then it's rhinoscopy, and before rhinoscopy, it's the bacterial fungal cultures, and we will talk about those, and histopathology. And in phase three, if we haven't found or reached up to a diagnosis, having done phase one and phase two, then we go for allergy testing, for viral testing, PCR. Maybe we can do interventional endoscopy because we've seen, for example, that the animal has a tumor, and we will proceed into laser debridement of the tumor, of the nasal tumor, or surgical exploration. Rhinotomies are we have overcome rhinotomies. It's very rare that we do rhinotomies in nowadays. There's no need. Okay, and let's go to the physical examination. So some dogs and cats, beware, will lick the nasal discharge. So it will not be, especially in early stages, it will not be prominent. Okay, so you have to really see, maybe look in the front legs if there are leftovers of nasal discharge, or ask the owners, okay, for head shaking sometimes. Look out for ulcerations on the nares, around the nares. Could be another disease like lupus, systemic lupus erythematosus, or dermatomyositis in the collie breeds, and they can give ulceration in the nose and then nasal discharge, but it could not be, a primary nasal disease. So we could have ulcerations for primary, secondary, due to excessive licking, rubbing, to chronicity of a disease, or to any systemic disease. Always auscultate the lungs, the trachea, and even in the brachycephalic breeds, you can do it. Even in cats, I do it. Please auscultate the rhinarium. You will have a lot. Sometimes I detect which side is blocked before the CT, because you can hear the air flowing into the rhinarium, okay, in the nasal cavities. So always close the mouth when you're doing that and occlude each nostril so that you can hear the air flowing into each nasal conchae. And how do we evaluate the patency of the nasal passages? You can have either a mirror or a glass slide, okay, and you put it in front of the nair so that you can see the moisture, okay. And another, this is most of the times this is what I do. And another thing is that you can have a tuft or some kind of hair or thread in front of the nostril, and you can observe the movement of the thread while the animal is inspirating and expirating, during inspiration and expiration, so that you can see the movement. If you see the movement, then air goes by back and forth. The next thing that we do is that I palpate all the area next to the nose, okay, for distortions, for swellings, to see if the area is more soft, because we have, for example, bone lysis. We have a destruction of the bone in the area, and it's softer. The sinuses as well. A percussion, always do a percussion, because you can understand if there's fluid accumulation, if there's muscle tissue accumulation in an area, for differences in densities. And also never forget to do the retropulsion in the eyes. You apply firm pressure, and you have to have resistance to this caudal displacement. And this way you can understand if, for example, you have something even behind the eye, something like a mass or something that's pressing the eye outwards to you, and you have an increased resistance. If you have any questions, because I don't want it to be a mere webinar. I really want us to discuss your experiences as well. Okay, and then the oral cavity examination, always in an alert animal and maybe in a sedated animal, because of course in cats it's very difficult to have a full examination of the oral cavity. Okay, inspection of the hard palate, the soft palate, of the tonsils and the pharynx, of the teeth, because as you know, the roots of the teeth go up to the nose, to the nasal conchae. So sometimes it's not a matter, and you have nasal discharge. So sometimes it's not a matter of nasal problem. It's more of a teeth, of a dentition problem. Okay. Check for ulcerations, check for masses. Okay, this is very protruding, the mass that I have here. But sometimes there are other masses that you cannot see. They're very, very tiny. And foreign bodies. We have a lot of animals that have foreign bodies. For example, grassones in the tonsils, in the pockets of the tonsils. So beware of all of those things if you see hypersalivation. And sometimes these migrating awns can go up to the nasal conchae. Okay. Look for injuries as well. Stick injuries are very, very common in the oral cavity that may go up to the nasal, to the nose as well. And of course, otoscopy for polyps to see if the eardrum is intact or not. So we have to perform all of those things before proceeding into rhinoscopy. Okay, and then once we have finished with the physical examination and with the clinical history, we go to our diagnostic workup, hematology, biochemistry, rule out, as we said, liver diseases in animals that have epistaxis or hemorrhage. Okay, coagulation assessment with PT, PTT, mostly PTT for liver patients, but also the BT, the bleeding time, okay, which is very, very easy in the lips, you can do it. Check for blood pressure and diseases that may cause high blood pressure. Just, measure a blood pressure. Do the easy stuff in your practice. I know that you have a huge case log and that you have to be surgeons, to be internal medicine people, but this really gives a great difference of quality in your work. Be meticulous and consistent and do safety checklist steps so as not to miss anything. Okay, hyperthyroidism, for example, here, renal disease, chronic kidney failure, pheochromocytoma, I don't even pronounce it correctly, and cardiac heart failure patients, okay, check their blood pressure before going into for endoscopy, and if needed, then you have to lower the blood pressure before going into, and not with ACP in a cardiac heart failure patient. Okay, you have to regulate the pressure and then go for rhinoscopy, maybe with ACE inhibitors. Okay, do vasodilation, and also do your aspergillus titers, which are not 100% diagnostic, but if you have a suspicion, you definitely have to do those as well. Phase 2, general anesthesia. And when you do when you have your general anesthesia, then you repeat your oral exam. In this phase, it's the whole imaging package. Okay, so at this phase, when we sedate an animal to go into the CT scan or to go into radiography, then we repeat the oral exam as well. We use this probe as well for the teeth, the Sulci probe. We do dental radiographs if we think that the problem lies there, okay? Thoracic radiographs, a lot of people ask me, when some animals are referred for rhinoscopy, the first thing that I ask is, pre-op blood works and everything, and thoracic radiographs. And they ask me, you're going to do a rhinoscopy. What do you need? Why don't you do, straight away your nasal radiographs, for example? Because if I have a geriatric patient and I have a suspicion for neoplastic lesions, I really want to see if there is a dissemination, neoplastic dissemination, or even if I have fungal rhinitis, for example, I really want to check out the lungs as well, either with radiographs or with a CT scan later on. Okay, and this is the time to have nasal cultures sample collection. So nasal cultures sample collection is before rhinoscopy, before the CT scan. Okay. Because otherwise you will ruin your I will tell you the reasons later on. Let me go into the radiographs, and then you will see why you cannot do it later on. I only want the histopathology during the rhinoscopy, the rhinoscopic procedures, because if you're doing the rhinoscopy and you're taking, okay, I'm going to reveal the reason. If you're doing the rhinoscopy and you want to take your cultures during the rhinoscopy procedure, the endoscope itself might actually give some bacterial infection in the nose. So the bacteria that you will culture might not be representative. Okay, and also during your rhinoscopy, use a lot of flushing, a lot of fluid going into the nose, and sometimes this dilutes your bacterial population. It detaches your bacterial population from the mucus. A good thing to do during rhinoscopy, though, is to take a tissue sample for culture. That's even better than doing the nasal cultures, but we will talk about nasal culturing a bit later. Let's see, we have a patient, and I'm not going to send him for CT scan. Which are the most representative radiographs that I need? And actually, do I need radiographs in order to get for rhinoscopy into rhinoscopy? What do you think? Do I need radiographs, or do I just, I have a sneezing patient. I see, for example, that he has a unilateral nasal discharge. So I go into this snare and I scope, because I know I'm guided through the nasal discharge, and I go into this snare and I scope. What do you think? Okay, let's see. Let's have a discussion. Of course we need, thank you. Of course we need not only radiographs. For me, CT scan is imperative as well. But for those of you who have not access, thank you. CT I prefer too. But for those of you who are in places and countries that this modality is either expensive or is out of reach for now, then you can have wonderful radiographic images, and you can be guided by that. Okay, so VD radiograph of the cuddled skull. You position your animal with the cross like that, and you get this view, which is very, very important. It has to be symmetrical. Don't forget to mention right, left, because I've seen that as well. And then we get a bit frustrated and confused. The nasal conchae, the bulla, you have a full image of what's going on. Okay. Another one is the open mouth. I always do the open mouth because it gives me very, very good view of the tympanic bullae as well. Okay. And this is under, of course, general anesthesia. And I rarely do this one, the DV intraoral. It's a very good view as well. You see that you put the radiographic plaque in the patient's mouth, okay, and the skyline. So most of the times I do a lateral. I do an open mouth, and I do the previous one, the VD, okay, and a skyline. In order to have the frontal sinuses, especially in cats, it's very, very imperative. And especially in animals that we are suspicious of aspergillosis, because there are some cases, we will talk about aspergillosis next time. And I will share with you some tips why you have refractory cases. For example, you do all this perplex procedure with Foley tubes, with turning some degrees every 20 minutes, 10 to 15 minutes, the animal. And you don't have a result. You only have a result, and then it recurs because you have a disease in the sinuses as well. So you have to address this problem in order for aspergillosis to be managed. Okay. And let's talk about the culture sample collection, because you're doing, as I said, this procedure. How much time do we have? Okay, we do have. We're doing the procedure, but we don't take the correct samples. So if you send a nasal discharge sample for culture, of course, you're going to have some, growth of a bacteria population. So are you going to give an antibiotic based on this bacterial population? Rarely these cultures are representative of the primary nasal disease. Okay, so don't spend your money or the owner's money into doing them unless you're certain that you will do one of those two techniques that I will propose to you, so that you can at least be more accurate in your culture and your cultural results. So always before rhinoscopy, always after radiographs, okay? Because if you go into, it's a traumatic procedure, especially in cats. We need to take deep swabs in order to have a cytology, for example, for cytology or for culture. So this is a traumatic procedure, and this will be depicted in your CT scan or in your radiographic, in your radiographs. So before rhinoscopy and after radiographs or after your CT scan, okay. Passage of the endoscope into the, we've said that if you put your scope in the nose, it might cause bacterial contamination, and also the intense saline irrigation might cause a reduction, a plasmatic reduction, a false reduction in the bacterial population. Okay, so the first technique is nasal swab through surgically prepared external layers. How do you do that? As you wash for your surgical sections, the same way you wash the nasal planum, okay? And you put your swab as far as it can go. And the second technique, which is a bit more perplexed, but it's, you know, it's a good one as well, because they have been compared and both of them can give more representative results. You put a small catheter, a 3 French or a 5 French. You need a syringe and you need sterile salines. I use the ampoules, the small ampoules of sterile saline, and I open them in a sterile way as well. So you place the catheter, and then you have an irrigation of the nasal cavity with a sterile saline, and you aspirate it as you aspirate the BAL, as you do the bronchial lavage. Okay, the bronchial alveolar lavage. This is the same, or the tracheal lavage. This is the same technique. But of course, your animal is sedated, and you have to secure the airways. The animal has to be intubated. And sometimes I put some packs of gauzes right behind, as I do for the rhinoscopy procedure. So it's easier to do the first technique in order to get some nasal swabs. But also, we always have to wonder about the validity and reliability of the results that we have from the culture sample collection. And if you want to have more representative results, then what you can do is, while you're doing the rhinoscopy, you can take your samples in the formalin fixed tube or the frames for histopathology, and then in a sterile Eppendorf. If you don't have a sterile Eppendorf, what I tend to do is that you have these containers, sterile containers that have a swab inside. So we, with gloves, surgical gloves, sterile surgical gloves, and a sterile scissors, we cut the swab from these sterile tubes that are meant, you know, for cultures, for ear cultures, for nose cultures, but we don't need the swab inside. Okay, so we cut it, but aseptically, and then we put inside sterile saline from these ampoules. And you can, inside, you can preserve tissue for culture. So we send off tissue, nasal tissue for culture, which is more representative. If you think that you have, you know, Mycobacterium, which is very difficult to culture, but if you think that you have some kind of bacterial infection. If you didn't get it, I will send you, please ask me how we do the tissue cultures, and I will repeat it because it's very, very important. And as many of you said, of course, we prefer the CT and the MRI scans. Most of the times, the CT scans, they have replaced the radiographs. Okay, both procedures, we can do both procedures, CT scan and rhinoscopy, under the same anesthesia if you have it in your premises well organized. Okay, the CT always prior rhinoscopy, because as we said, if you just put the animal for rhinoscopy and then you need a CT scan, then you have traumatized the nasal conchae, so you can not do the CT scan. And besides that, you need to organize your procedure. You need to see the extension of the lesions, the borders, the delineation of the nasal tumor, for example, or of the inflammation. And it's not only that. It's that you have to organize your procedure, but also if you have a huge tumor, then it's okay. You will see it when you do the rhinoscopy, but sometimes you might miss small lesions if you do your rhinoscopy blindly. Okay. And of course, the collection of the samples, if you want to see culture, we're talking about culture swabs after the CT scan. Okay, as we said before. So here we have a patient, and this patient, of course, is under general anesthesia. In sternal recumbency, the CT scan always. Okay, and the forelimbs retracted, the collar always removed, and we have slices of 1 millimeter, 1.25 millimeters, but 1 millimeter are very, very good slices so that we cannot miss any lesions. And from the tip of the nose up to the level of the third cervical vertebra. I tend to have a total body CT scan when I do CT scans for the nose, because especially when I have a geriatric patient, when I'm worried about distal metastatic events. So I always do the thorax as well, and the abdomen, because you don't know, you might have, liver cancer, for example, or in other places. So we definitely I prefer to do a total body CT scan. But if you only do one region for financial purposes, make sure that we include the retropharyngeal lymph nodes in these sections as well. And as you see, we have on the left side, on the left nasal area, we have a mass. This could actually be fluid accumulation as well, but we can do, there are certain techniques that you can detect the mass from the fluid accumulation, and you can do with contrast medium as well. And let's see the instrumentation for those of you who do not have a scope yet and do not know what to pick, because there are a lot of things out there. So let me, this is the one of the towers that we have at the clinic. So you can see here we have the OR 100, which by itself can attach both flexible and rigid scope. It has a monitor on it, the light source, everything is on this monitor. Okay, and this is portable. And I also have my non-portable unit. And in this unit, you can also attach both the flexible and the rigid scope. You see my pump, my irrigation pump. Aohua has an irrigation pump for in order to give more fluid, and you can use that for colonoscopy in order to enhance your preparation in the intestine. You can use it in cystoscopy. Please be very careful in cystoscopy because it's very, very aggressive irrigation, and you can, if you close if you close the entrance, then in the vagina, in order for water to accumulate, then you might rupture the bladder. It has happened. Okay. And this is why you will see that in this photograph, I have my saline very low because I have attached it to my irrigation pump. If you don't have an irrigation pump, then you need your saline to be much higher up. okay, at least 70 centimeters higher from your patient. Always the buttons up front on you, as you see. And you see my hand here handing the light source. And this is actually my handle. The handle is the light source. So we'll see the equipment. This is the seat, the cystoscopy seat that I use. I hope that you can see my arrow where I'm pointing. Okay. And this is another seat especially designed by Aohua for rhinoscopy, the working channel. This is where we attach this is where we take the biopsies, and this is where we attach the light source and the saline, the irrigation. Okay, you can have it with a handle, or you can take the handle off. Okay, it's as you wish. And we're going to talk a bit about rigid rhinoscopy. We're going to talk next time about the flexible one and the retrograde rhinoscopy. The instrumentation. So rigid scopes and seats, do not put your scope in the nose without a sheath. Do not put your scope anywhere without a sheath. You have to protect your scope. And this is the OR 100 that I had in my practice and showed you, and you see how it is attached. Okay, most of the times you will use for any endoscopic procedure your multi-purpose 2.7 millimeters scope. The diameter is 2.7. The angulation is 30 degrees. I do not like the 0 degrees. It's only for laparoscopic work. And the length is around 18 centimeters, which means that you can examine the nose of a tiny cat and a big dog, not a tiny cat, a normal cat of 3 to 4 kilos, up to a Great Dane. For Great Danes, of course, I might use the bigger scope, which is like the laparoscope that we use. And for tiny, tiny cats, I will show you the instrumentation. So always a cystoscopy or operating sheath. The operating sheath is just to diagnose something. It doesn't have a working channel. So I would prefer to have the cystoscopy sheath, because sometimes you're looking for the foreign body and you cannot just take out the scope and reintroduce it. So why are there is there the operating sheath? The operating sheath has a smaller diameter. So it makes your life easier to get in with the operating sheath and have a diagnostic, overview, because the cystoscopy sheath is much, much bigger and it doesn't leave a lot of space for you to move. But even having said that, it's much better to get in with a cystoscopy sheath in order to, from minute 0, to be able to do interventional work if you need to take biopsies, to retrieve a foreign body, and not to have to change the sheaths throughout the procedure. So these are the cystoscopy sheaths. So this is our scope, and you definitely need an alligator grasping forceps and a biopsy forceps. These two are imperative. And you can have a loop electrode, in order to cauterize something if you like. And this goes through the scope as well. And there are some other instruments, the biopsy forceps and the alligator forceps that we have here. These are flexible. Okay, these are very, very tiny and flexible. You can have semi-flexible, like this one on the left, and you can have harder instruments as well in order to grasp bigger biopsies, in order to take out nasal tumor. You will need a firmer grasp, and you can do it sideways from your scope. So there are there's a huge range of instruments that you can use for debridement of a nasal tumor, for example. what other instrumentation is out there? As we said, the irrigation pump, use it very cautiously, put it in the lower, in step 1, in intensity 1 as you begin, and then you can make it, even more intense, the irrigation more intense, especially if you have a lot of hemorrhage. Okay, and you might also use in your endoscopic procedures laser fibers, and the sizes that you need is 400, 600, and 1000. Most of the times it's 400 to 600. With the 600, you can do a lot of things. Okay, with 600 laser fibers. So if you have to choose one, maybe you can choose the 600. Other accessories that we use in rhinoscopy procedures. I don't know if Aohua has nasal stents. Jason will tell us. I have used the Aohua stents for tracheal stenting, but for the nasopharynx, the sizes that we need are from 8 millimeters to 14 millimeters, and the length varies, and some of them are tailor-made, are customized. Infinity Medical's Boston Scientific have amazing stents as well. And Jason will tell us about if Aohua is cooperating with a company for nasopharyngeal stents.
Yes.
And
I will check it later.
Please, and we will let you know. Balloon, also the diameters for the nasopharynx is from 6 to 18 millimeters. And I always use the triple expansion balloon dilators. Okay, this is for cats, and the medium. So the medium for cats is around 9 millimeters balloon. They're very tiny balloons. We use those in people for the common bile duct. And from 10 to 12 millimeters in dogs as well. The medium 11 millimeters for dogs. And I think that it's up to 18 millimeters for dogs as well, but the median is lower. It's a mistake here. So 6 to 18 millimeters in general for the nasopharynx for dogs and cats, a median 9 millimeters for cats, and a median 11 millimeters, 11 to 12 millimeters for dogs will work fine. Okay, so that you know what to buy for these procedures. You might even have these small balloons for esophageal strictures in kittens and puppies, mostly in kittens. So the 12 millimeter balloon, for example, is a starter in our kit for esophageal strictures in very, very tiny kittens. And this is a guide wire, because we will need the guide wire. This is the same guide wire that we put in the trachea in order to, in the esophagus when we're measuring for tracheal stents. And it has a demarcation, it has marks, this guide wire. And we can use that for the balloon dilation procedure as well in cats and dogs. And we will talk about the balloon dilation in the nasopharynx the next time. Okay, patient preparation. So you see that, as we said, complete history, physical examination, coagulation profile, radiographs, and CT, fasting for 12 hours. The general anesthesia is mandatory. You have to choose, you have to intubate, and you have to use a well-cuffed ET tube, and mouth gags. Always the mouth gags. We are in the procedure of sedating this animal. This is why I haven't put a mouth gag. You see that blood comes out of his mouth, blood comes out of the nose as well. It was one nostril, actually. It was unilateral disease in this one. And then sometimes I put 2 mouth gags. Beware of the cats in order for them not to open the mouth gags very in a great distance, because they might wake up blind due to the reflex there. And also beware of the overextension of the jaws when you're doing manipulations in the because you will be with a rigid scope in the nose, and you will have an extension of the jaws. So please beware of this extension. Make it a bit lower, because you might cause trauma to the junctions. Also, another thing that I really want to highlight here is that I know that a lot of you, just before going into a rhinoscopy procedure, you're giving non-steroidals. But if you have any suspicion that this might cause problems in if any suspicion that you have a coagulation problem, then it's due to the inhibitory effect that they have on platelet aggregation. Then please think twice before administering non-steroidals. And also the A2 agonists may cause hypertension. So be really, really cautious if you have epistaxis or hemorrhage. Okay. We do ACP pre-medication, and also think about ACP even after the procedure. We can use butorphanol, buprenorphine, pethidine. I don't know, what you're more familiar with or what's available in your countries. And the patient positioning, as you see, is with sternal recumbency, and we put a towel also because we really want to actually close the pharynx, and this secures also the position for the pharynx as well. This is a cat, and as you see how I'm holding, I always put a bucket and a towel just in front of me. Okay, and this is my irrigation pump, and this is how I'm holding the scope in order to get in. But then I will show you how you should hold your scope during the procedure. So we definitely pack the caudal pharynx with gauze swabs to protect the larynx. Okay, I use a lot of swabs, but please beware and be cautious to get them out before your animal starts waking. The fluid container should be higher up unless you have an irrigation pump. Okay, and the IV drip set control opened fully. And what we do is that we open the IV drip, and the fluid control is controlled by the scope here. Okay, by these but the stopcocks from on our seat. Okay, it's much easier this way. The mouth is always open. We don't close the mouth with the mouth gut, so that we can let all the fluid go out from the soft palate. Well-sealed trachea, well-inflated cuff. Okay, we attach the saline in the inlet port of the scope with the set of the saline, the given set of the saline, and we open the top of the given set. We lift, as we said, the alar cartilage, and we insert the scope in a ventromedial direction. We don't go upwards. As we enter, we don't go upwards. We go into a ventromedial direction. Okay. It's going to be a bit theoretical, but we're going to show it in pictures maybe next time. So you grasp the insertion tube. If this is the insertion tube of your scope, okay, you grasp it with your thumb and the finger, and then you go into the bridge of the nose for stability. You have to both grasp your scope and the bridge of the nose. You need the head of the animal to be very, very stable. You will not hold your scope, as I have seen, with two hands. you will hold your scope with one hand, and the bridge, sometimes it's with the left hand, you know, and you hold the bridge of the scope of the nose with the remaining left hand. Sometimes it's with your right hand, whatever suits you better. I tend to grasp my scope with my right hand, and then I go and grasp with these two fingers my scope, and with the remaining fingers, I grasp the face of the nose of the animal so that I can have a firmer grip. Okay. Always maintain the camera in upright position as I've shown you. Otherwise, you will be confused and disoriented. And you examine all the meati, the dorsal, the medial, the common, and the ventral meati. The ventral meatus and the common meatus, as we said, go back to the nasopharynx, to the choana and the nasopharynx, and this is where you stop when you have reached the nasopharynx, but orthograde from not retrograde, okay? You use aggressive flow. Watch out, because I've seen a lot of hypothermic patients with cold water. You reduce the hemorrhage, but you might cause hypothermia. You might also cut saline bags, and you might, you know, use just water, not sterile saline, if you like. All of the times I use sterile saline. Avoid the rapid movements. Whatever you do in the bladder, in the urinary bladder, and in the nose should be very, very gentle movements, because you might cause trauma and you might have hemorrhage. And you might rotate from the handle of your light source, your scope, 90 degrees, so that you can see all the lesions, you know, all over. You do not rotate the whole scope. You take the light source and you can rotate the light source, and this way your camera is rotating. Okay. And always keep in mind that you have 30 degrees angulation, which means that you have to keep the lumen in the bottom of your screen. Okay. First thing you see in the rostral nares is this picture here, which is, you know, very smooth, pinkish. Sometimes I will show you, they could have pigmentation. But there are this is the most smooth part of the nose. If you see this picture, you know that you're rostrally, you are not back in the ethmoid turbinates, for example. So when you get in, the nasal turbinates are really, really smooth and do not have a lot of ups and downs, you will see. The common meatus medially between the nasal septum and the ventral meatus is the easiest way to follow. So when you go in, the first picture you see is the one that I have here. Okay. Then you check to find the nasal septum, because this is your landmark of orientation. And it's flat and smooth. And always remember that the common meatus and the ventral meatus lead to the nasopharynx. The dorsal meatus lead to the ethmoid area, and you will see the light of your scope in the eye of the animal. Okay. This is a different picture with a pigmentation. And when you see pigmentation, you know that you're very, very rostrally, even if I haven't told you this. And this is the branching in the right picture. This is the branching of the ventral nasal conchae. So this means that you passed the way of the rostral nares. We will go step by step in order for you to know how to orient yourself. So after this part here on the left, we go on the picture on the right, and this is the branching of the ventral nasal conchae. And from this part and on, we start to have the nasal turbinates, okay, and the ethmoidal turbinates. These are the ethmoidal turbinates, and the ethmoidal turbinates have spaces between them, have a line of space between them, not much space, but they're not condensed. And once you reach this point, you know that you're past the nasal conchae into the ethmoid turbinates. This here is the septum. You see how the septum is flat and pink, and it's a landmark of orientation. This is here the nasopharynx, okay, but from the orthograde position. And this is the vasculature of the nasopharynx. And this is the Eustachian landmark that it's, you know, the landmark of the ear as well. So you see that there are certain landmarks, and we will talk. I don't think that we have the time. How much of a time do we have, Jason, in order to talk a bit more?
Yeah, I think maybe 15 minutes.
Okay. No, we're going to talk about the procedure, and we're going to have some cases and balloon dilations and interventional procedures next time, but we have to define the landmarks first. So you see here the Eustachian tube in the nasopharynx. This is a landmark of the nasopharynx as well. You really need to orientate yourself when you're in the nose, okay? And then once you went ventrally, you lost the light of your scope, you went back to the nasopharynx, okay? And you've seen all these landmarks. You can go dorsally and in the middle meatus as well in order to check this phase as well. Let's have the foreign body scoping. And this was actually from the patient that you saw with the blood on the face. Sometimes it's very tricky to see the foreign bodies. And what I want you to tell me here is where we are located based on what we have said. Sometimes you see protruding just a very, very slight part of the grass own, and if you take that, then you will miss the rest of the foreign body. So you have to go a bit deeper and search for the stem of the grass own from the base. And sometimes you grasp tissue as well, and it gets really, really bleedy. So this is not the correct approach that I'm showing you here. Even though the whole grass own got out, you could have missed it. Sometimes you have to go 2 and 3 times in order to take the own out. Okay, so this is pretty much it for today. We talked about indications, about the correct instrumentation. So next time, we're going to go into cases for both diagnostic and interventional. We're going to check how lymphoplasmacytic rhinitis is. In normal noses, the mucosa is smooth, it's pink. Sometimes it's different, you know, with the air. When you see with the otoscope, it's the image that you have is totally different than the image that you have with the flushing, with the irrigation and the water, the fluid. So it's a bit trickier to check the mucosa and to see the lesions with a small otoscope, even with the video otoscope. And it's totally different with the rhinoscope because you have all the flushing and irrigation. Also, the mucosa should not have any nasal discharge in order to be normal. It's pinkish. it doesn't have any lymphoid follicles, you know, like nodules that we have in lymphoplasmacytic rhinitis or in chronic nasal discharge that we see in the nasopharynx. Lots of the times when we do retrograde rhinoscopy, we see a lot of nodules in the nasopharynx. So it has to be free of all of those things. And next time we're going to talk about the more interesting stuff. But for those of you who are beginners, I think it's a very good basis in order for you to get to know how to orientate yourself and how to distinguish between the nasal turbinates, the ethmoid turbinates, the nasopharynx, the area of the nasopharynx, and the septum, which are our landmarks. And whenever we are confused, we are disoriented, and we don't know where we are, we retract, we see where we are, and then we proceed again. Because in the nose, we don't have the luxury to do a lot of attempts, as in gastroscopy or colonoscopy, for example, because we have a lot of hemorrhages that we have to deal with, and sometimes a lot of nasal discharge or mucopurulent discharges that blur our picture. Okay. Any questions for this preliminary webinar? And next time, for those of you who are more advanced, I think that you will enjoy next time.
Yeah, if you have any questions, please put it in the Q&A boxes. Dr. Vasiliki is willing to solve your problem.
Thank you very much for attending. This was for the beginners. Next time we will have something for the advanced as well. But there are very good tips about your cultures, about the procedures, about how you should do things. And next time we will have comparative videos, more endoscopic videos now that you know the anatomy and you know the procedure. We will have videos with cases so that you can all participate. Okay. What should we do for consulate our about a consultation? You can email me. You can email me, and I will put in the chat box my email for everyone. We can have Zoom meetings, you know, whatever case you have. We can discuss about it. And even if you do your, I think that everyone is seeing my email. Even if you have a difficult case, you know, and you've done your CT scans and you've done your procedure, your endoscopic procedure, not only the rhinoscopy procedure, any kind of endoscopic procedures, we can discuss. Thank you very much. I know that for me, this is very, very basic, but it's very important for you to understand. Any other questions? Can you use flexible endoscopy for these purpose? Hi, Babak, first of all. I'm very happy that you were here. It is possible. I know that some people for orthograde rhinoscopy, they use flexible scope, but it's very, you do not have the irrigation. And up to now, we do not have the adapter to put the irrigation pump on the flexible scope. Correct, Jason? Is that correct?
I think we have found the adapter, and now we have our smallest scope.
If you have an adapter, good, very good.
Yeah,
if you have the adapter for the irrigation pump, this will make your life easier. But the flexible scope that gets into the nose is very, very thin. You will not have a good image. The rigid scopes gives you a better image for endoscopy, but we will use the flexible endoscope for retrograde rhinoscopy. For retrograde rhinoscopy, where we want to see the choana in the nasopharynx, then this is what we will do, and we will explain the technique.
And I want
Thank you very much, and my greetings to all my friends in Iran.
Yeah, Dr. Vasilik, I want to share information to you because we have now we have a smallest scope which the head of diameter is 2.8 with 1.2 working channel. And
Okay.
I think this might be good for the rinoscope. Well, we have do some demonstration on the otoscope, and it can, reach deeper than the rigid one, and it can reach to the middle of the ear. But
Okay.
maybe after we have some scope, maybe you can test it about at the rinoscope.
Good. So, Alexandra, hi, how are you? You will tell me, where do you think it was? We talked about anatomy. We're going to talk about foreign bodies the next time with a lot of videos, but we talked about anatomy. And this is why I wanted you to see. Let's go back a bit. Let's go back a bit and just watch it one last time. Okay. I'm sorry, Jason.
It's okay. Everyone's enjoyed this presentation.
One more minute. You see the vasculature, okay? You see that you have ethmoid turbinates. You see the line between the turbinates, okay? It was very, very deep because most of the grass ones that you have will be found with the otoscope. So I use my, and you see the septum as well. So you have your orientation, you can be oriented this way. But these were ethmoid turbinates and your septum, okay? On the right side. I know that its anatomy is always very boring, but especially in the nose, it's very, very important to know where you are. You have your nasal turbinates, your ethmoid turbinates, your septum, and some other landmarks. The nasopharynx is always very easy. The landmark of the eustachian tube, for example, which is back in the nasopharynx. But most of the people are disoriented in the rostral nares in the ethmoid turbinates. They do not know where they are. Now, if you're dorsally, middle, or ventrally, then it's easy to orientate with the light of the scope, as I told you. When you don't see the light of the scope, you're ventrally. So you can go on to the nasopharynx. If you see the light of the scope, then you're up here. Okay, you're dorsally. This is a very, very quick and easy way to orientate yourself. Any other questions? Thank you very much for spending some time with me. And please do not hesitate to email me whatever you need.
Thank you everyone for attending. If you think our webinar is interesting and you wanna attend the next month, please follow us social media and we will send an invitation on it. And we also have some cases which show up today, and we will make it and put it on the YouTube channel. Yeah, you can have a see.
Christoph, can you go to the sinus with the rhinoscope? Yes, but not from the nose. You will have a drill, a very small drill, and please beware of not going into the brain. you will have a drill and have a small hole, and then you can go into the sinus with a rigid scope. Definitely. We should do it. Sinusoscopy is a part of the rhinoscopy procedure. And especially if you have in your CT scan or in your if you in your radiographic images, lesions of the sinuses, you definitely have to go in and explore that as well. But you do it with a drill. Section, drill, and then you put your scope. We will have a chance to talk more next time. Thank you too. Thank you too, Christoph. About interventional procedures. We're going to talk about aspergillosis, the positioning of the animal, how we treat these cases, foreign bodies, nasopharyngeal stenosis, polyps, which is very, very common. Okay, and we can treat that. Thank you, and have a great day, everyone. With many cases and many successful procedures. Thank you for your interest in veterinary endoscopy.
The dates we will make a decision after several days, and I think it will be the end of the December.
It will be around the end of December. It's 1 month from now, but maybe we will do it before Christmas, you know, or before the festive period. But I will be in Turkey, in Antalya for the emergency, for the TÜVEKA Congress. And we will talk about not rhinoscopy, we will talk about protein-losing enteropathies and laryngoscopy. So for those of you who are from Turkey, I'm waiting to meet you in life, in person there.
Good.
Thank you very much, Burku.